Good morning, all, and I would like to begin by welcoming everyone to this meeting of the joint Cambridgeshire and Peterborough Health and Wellbeing Board and Integrated Care Partnership at New Shire Hall. Filming and photography are allowed at this meeting, so please feel free to take pictures and use social media during the meeting. Can I ask, though, please, that everyone turn their mobile phones to silent or vibrate whilst the meeting is taking place. Please be aware that this meeting is being live streamed and that a recording of the meeting will be available to view on the County Council's website. There is no fire alarm test scheduled for today, so if the alarm sounds, please leave by the nearest marked fire exit and assemble in the car park. The closest fire escape is through the middle doors on my left, past the water closet and kitchen. Now we move on to item 1, apologies for absence and declarations of interest. Would the Head of Governance and Data Protection Officer please report any apologies for absence?
Thank you, Chair. The apologies we have today is we've got apologies from Professor Steve Barnett, John Gregg, Dr. Zoe Hutchinson, Mayor Dr. Johnson. We've got apologies from Judd Thomas, Dara Preston, Mike Moore, and Louise Comfer. Thank you.
Thank you. Are there any declarations of interest?
Sorry, just on the apologies, was Richard Howard mentioned there? Chair of Adults and Health.
Yeah,
so I'm here substituting.
As a substitute, yeah, we can add that to the apologies. Members, I will begin the meeting with a roll call to establish who is present. When I call out your name or the name of the individual for which you are substituting, please confirm your attendance with your name and your title. So I'll start with myself, Saqib Farouk from Peterborough City Council. And next is John O'Brien.
Good morning, everybody. Yeah.
Kit Connick.
Morning, everybody.
Jed Curran.
Yes, good morning.
Good morning. Louis Camphor. And Jan Thomas, we have apologies. Jyoti Atri. Councillor Ray Bisbee.
Yes, here. Thank you.
Rob Bridge.
Hi, yeah, I'm on screen. Thank you.
Paul Med.
Hi, good morning.
Councillor Susan van der Ven.
Hello, thanks.
Liz Watts.
Morning, everybody.
Professor John Woolwork. Dr. Neil Moder. We don't have. Julie Farrow.
Morning, everyone.
And Claire Higgins. No. We also have, I believe, Mary Elford, Steve Barnett, and Rob Bridge joining us virtually. Is there anyone here that we have missed?
Yeah, here's Richard, self-innovation.
I think so. Okay, so if we start with yourself, Stephen Taylor, if you haven't been called, if you introduce yourself.
Morning all, I'm Stephen Taylor, the Executive Director of Adult Social Care and Commissioning for Peterborough.
Hello, Mike Black. I'm a councillor in Cambridgeshire, a member of the Adults and Health Committee. I'm substituting for the Chair of the Adults and Health Committee, Richard Howard.
And yourself?
Piers Ricketts, former Academic Health Science Network.
Thank you. Apologies all for the mix-up. So now we move on. Sorry, Patrick.
Thank you, Patrick Warren Higgs. I'm the Executive Director for Adults Health and Commissioning at Cambridgeshire County Council. And there's the.
And yourself.
And Stuart Francis, Chair of Health Watch.
Perfect, thank you. Sorry, I know you've just arrived. Could I ask you to introduce yourself, please? Thank you.
Hello, I'm Dr. Neil Moder. I'm a GP from Thistlemore and representing the North.
Welcome all. Thank you very much for that. We now move on to item 2, minutes of the Cambridgeshire and Peterborough Health and Wellbeing Board Integrated Care Partnership, 20th of October 2023. We are being asked to approve the minutes of the Health and Wellbeing Board Integrated Care Partnership on 20th of October as an accurate record. If any board member wants to raise a question on the accuracy of the minutes only, they can do so now. Go ahead.
Yeah, could I just ask a question about item 7 AOP on the minutes? If you look at the second paragraph, I think I know what it's supposed to say, but I don't understand it. I don't think it possibly says what it should do. That's the key theme with smoke-free generation, makes it illegal for anyone who is 14 years to purchase a cigarette. I mean, I'd assume that that's always been illegal, but yeah, but so I think I know what it means, but it probably needs changing for accuracy.
Yeah, I think it probably does. So if the smoke-free generation comes in, any child who is 14 today will never be able to legally buy a cigarette. That's what it should say.
Thank you very much. On that basis, are board members happy to approve the minutes as written? Thank you very much. We now move on to item number 3, which is the Health and Wellbeing Board Integrated Care System Strategy Priority 1, Children's Update. Please can I ask Raj Laxman to introduce this item?
Thank you. I'll let John and Steve, who are standing in as voice.
Hi, should we introduce ourselves first? So I'm Jonathan Lewis. I'm Director of Education for Cambridge County Council.
Thanks. And I'm Steve Bush, Director of Children and Young People Services at Cambridgeshire Community Services NHS Trust.
I'm Raj Lakshman, Consultant Public Health, Lead for Children and Clinical Policies. And we've got Helen Freeman.
I work with Raj, the children's team in public health.
So thanks. Just to briefly introduce. So obviously we came to this group some time ago when we launched this work stream. The report we present to you today gives progress against the 10 deliverables of the work stream that we are leading on. I have to say this is an ambitious work stream. This is about system change. This is about driving difference into our children and young people. I think what you will see from the report is that we are making significant progress in terms of the actions against them, in terms of making difference, in terms of tangible outcomes, in terms of the key deliverables. So engagement in early education, NEET will take more time, but I'm really positive with the actions we are taking are starting to come to fruition, and there is good progress with people working together. I would draw you in the report, particularly, and we will go into some more detail. I'm really keen that we have a chance for discussion today, is that this is all about partnership. 2.6 of the report outlines the steps where working together is critical, and that's across all aspects of our partnership and through those organisations represented around the table today. But I think it's also important to highlight in 2.7 of the report the challenges that we face, particularly in the children and young people's arena. We see the impact of elements of such as coming out of COVID, the cost of living crisis, and the challenges we face around public sector delivery, financial, staff and other aspects. So I think, very highly commend the progress that we are making. We're very happy to take questions on that. And I think there's a lot of work to do, but, I'm pleased that we can report such a positive position on progress today. Now, obviously, as part of the papers, there is a detailed presentation. There is obviously the report gives a summary to that. I think I may defer to other colleagues to any comments they wish to make, and then probably I suggest we open it up rather than going into a huge amount of detail on those factors around the sort of elements that you see within the report presented. So, Raj or Steve, is there anything you want to add to that lead?
Thanks a lot, John. And yeah, as John said, we wanted to have more time to discuss the challenges and how we as a board can address some of those challenges. we can go over the presentation very quickly and pick out any salient points on each of the slides in about 15-20 minutes, and then have more time for discussion. So as it says, our priorities to ensure children are ready to enter and exit education, well prepared. We will go, what we'll cover would be demography, to how our population is changing, and the main vulnerable groups which we as a system are responsible for and have a lot of statutory duties towards are children with special educational needs and children in care, and then children living in poverty are vulnerable apart from some of the other vulnerable groups. We want to agree at this Health and Wellbeing Board our ambitions, which we'll detail, and the targets that we have set for those ambitions. And as John said, we just quickly skim over the achievements that we've made, but it would be good to focus on the challenges and where we need system support. So again, demography, it just shows this slide that child population in Peterborough, particularly in Peterborough and in Cambridge City, it's been increasing, and by more than a third, which is important for us to recognize in terms of making sure there's enough health and care services and education places as well. Again, this is just data on the special educational needs children and children in care. I won't go into details of all of those, just the slides are there just to point out that these are our most vulnerable children, and then children living in poverty as well. On the previous slide, I think it's important to say that although we say Peterborough is worse than East England, with 25% of Peterborough children living in poverty and 11% of Cambridgeshire, there are pockets in Cambridgeshire which are have a high percentage of children living in poverty, and we are in the process of completing a Children and Young People's Joint Strategic Needs Assessment, which will go into details of some of these issues. The important slide here is the targets. As John said, we've got a target for quite ambitious targets for improving the percentage of children who show a good level of development when they enter education, up to 70% in Cambridgeshire and Peterborough. So Peterborough Director of Education specifically asked us to put in quite an ambitious target for that in Peterborough. So there'll be a lot of work to do around that. And then we want to reduce the proportion of children who are not in education, employment or training from 3% to 2% in Cambridgeshire and from 5% to 3% in Peterborough. And we want to reduce inequalities in both of these outcomes. These next few slides just go into details about why we think school readiness or a good level of development is important. It has long-term implications. It's not just at that point in the child's life. It is right up in terms of mortality and morbidity throughout life. So we need to set them on the right trajectory right from the start. And in terms of inequalities, again, we can see that children in most deprived areas have the poorest levels of school readiness. We can see again in Cambridge and Peterborough, the children on free school meals have worse or pupil premium have worse percentages of showing much lower percentages showing good level of development when they enter education, and we can see ethnic differences as well. Again, not in employment, education and training, why it's important in terms of mental health, physical health, and involvement in crime and lower life expectancy. And that's the reason we've chosen these two ambitions. And again, the slide just to show that there are inequalities in the percentage of children who are neat across deprivation and across ethnicities, with, again, white and mixed ethnicities having more percentage and those unknown having higher percentage who are in need. So again, this slide is just to show some of those inequalities. Recently, school attendance has become more of a national and a local priority because post-pandemic persistent absenteeism has gone up. And if children are not in school, it's like adults, if they're not in employment, it's not good for their health. So if children are not in school, that's not good either for their educational or health outcomes. And again, this slide just shows that the inequalities are stark in terms of pupils on free school meals, 21 days lost versus 12 who are non-free school meals. Who have, again, I won't go into details, they're all there in the slides. And again, why we think it's so important in terms of having school attendance as a focus because of the inequalities that we see in that. As I said, it's gone up post-pandemic, and persistent absenteeism has gone up as well. In terms of achievements, we coordinate the entering education through the Family Hubs program, which was previously the Best Start in Life program. And now, since there's funding in Peterborough specifically, we've got the Family Hubs program, which we work across Cambridgeshire and Peterborough. And the exiting education ambition is delivered or coordinated through the School-Aged Health Improvement Partnership. We'll quickly go into some of the deliverables. The first 5 are for entering education, and then there's some for exiting education. Again, the list of vulnerable groups, apart from the ones I mentioned before, we have to be careful about young carers, young offenders, young parents, and children from traveller communities are most vulnerable as well. I'll hand over to Helen if you want to quickly run through some of the slides on the Family Hubs delivery plan.
Yeah, no, happy to. So as Raj says, they're all in your pack, so they're quite full slides. So I'll just kind of pick out a couple of things on each one. The Healthy Start Scheme, for those of you who don't know, this is funding that is available to support families with healthy food and vitamins, both during pregnancy and for those families up to the age of 4. This is for families on low incomes. We've seen good increases in take-up. We still are working with community partners to try to make sure that as many people as possible know about that. We now have a robust offer in terms of where families can get hold of vitamins that was missing before. So we've worked in conjunction with child and family centres to make sure that vitamins are available across Cambridgeshire and Peterborough. And we now are just trying to kind of make families want to come in and take those vitamins. So there's a big piece of comms about the importance of those. So support on that is always welcome. Deliverable 2, as part of the Family Hubs programme, there is an element of that which is the Start for Life offer. That is particularly about us making sure that we have a really robust offer to families in that first 1,001 critical days. So that's the period from pregnancy to the 2nd birthday, and making it really clear for families what support is available out there and how to access that support. So we've started a piece of work to bring together the information to families. There's now a Start for Life offer that is hosted on the Peterborough City Council page and also on the Cambridgeshire County Council page. And we've worked with key system partners to make sure that families are told about that. So it now goes out in key maternity publications to go out to all families, and we're looking at other opportunities for how do we make sure that as many people as possible know where to get that information. The third one is around perinatal mental health and parent-infant relationships. Obviously, we know that the outcomes of children is really affected by the mental health of the family, and particularly that bond, that parent-infant relationship between the key carer and the child. So we've been making sure that we have the structures in place across the system to bring together all of those different agencies that are involved in this piece of work. We've been looking at what are the areas we're particularly worried about. We now have 7 key outcomes that have been agreed across the partnership. We are aware that we have poorer outcomes for certain groups, so we're working closely with the new Maternity Equity Hub, which has now been branded as Mama. It's being launched next week, so some of you may have had information about that, to make sure that particularly the outcomes for our Black and ethnic minority families are really centred to that, because we know they're not anywhere near as good as they should be. We are launching a pilot in Peterborough of a new parent-infant relationships team that's been fully recruited to and is becoming operational this month. That will help to give those families where we know there are the start of attachment problems and there isn't that bond, it will give them some really specific work that's led by a clinical psychologist that sits within the Healthy Child programme. So it's also very much embedded into the work our health visitors are doing. Deliverable 4 is around infant feeding support. There was already a cross-system strategy that had been signed up to by key partners around how we support infant feeding, about how we improve our breastfeeding rates and how we improve that support. There's a real crossover between this deliverable and deliverable 3, because we know that a new parent's feeding journey also impacts in terms of their mental health. So we've very much looked at how we can make sure we're offering feeding support as well as emotional health and wellbeing support. We have a new peer support programme that has just been commissioned with the NCT that is bringing together support on both of those issues. We have a new website that makes it easier for families to know where community support is. So they can type in where they live or what day of the week they want support, and will be told where they can go for a face-to-face or an online support group. And deliverable 5 is around providing families with the support and advice they need to access early years and childcare opportunities. This is very much led by colleagues in the early years education teams. We're particularly kind of proud of the embedding of the 50 Things Before You're 5 app. Lots of people are using it and lots more resources are going on that all of the time. It's also being supported by partners across the system. So hopefully the health visitor would let a family know about it. The activities are modelled in child and family centres, and obviously our early years settings are using them. So it's really helping to put that support around parents of things that they can do with their children, which are low cost, which are things that we know have high value but are low cost. We also have still had some great results from the HAF programme, the Holidays Activity and Food programme, with, as you'll see on there, a large number of children from across the area taking advantage of that. I've taken up only a few things, there's lots more in there. Do you want me to move on to deliverable 6?
Yeah, so again, deliverable 6 is about ensuring dam-free accommodation for children with a respiratory condition. We'd agreed this before all the thing in the news. We work in partnership with the Housing and Health Priority on this deliverable. Improving immunization rates, again, that's an important issue to keep children in school. If they're immunized, they're more likely not to get some of the infections, so the flu immunization and prior to that, and measles. We're hearing more and more about the measles outbreaks, and then children who are contacts can't be in school for 21 days if they've not had their immunizations. So immunizations always up on the agenda. We said we would, in terms of reducing need, we would increase apprenticeships through anchor institutions, such as all of us around the table. And again, some data to share about increase in apprenticeships. Improving mental health, emotional well-being. Again, this is done in collaboration with the mental health priority, so priority 4. And I won't go into details of this, but there's a lot of work happening across that priority. You'll have more details in the next Health and Wellbeing Board, when priority 4, there's a focus on priority 4. We do that in partnership with priority 4. In terms of establishing a mechanism to improve health outcomes for our school-aged population, we've just had 2 meetings of the SHIP, the School-Aged Health Improvement Partnership. It has been established to coordinate and streamline activity because there's a lot of health input going into schools. Schools have been telling us it can get quite confusing. There's lots of different agencies communicating lots of different things. And also we need to look at the totality of the resource and how to best make use of that. So we've set up that board with Jyoti chairs along with the 2 directors of education, and it has representations from schools and across the system. That was important to make sure that the head teacher voices are heard, and John was quite keen that they shouldn't, that should be the focus, that we need to understand what exactly is going on in schools. And they've and at the ship, the initial priorities have been identified, which we're working through and addressing as we go through the year. And so in terms of challenges, maybe I wanted to pause here to talk about how we address these as a system. There's just one more slide just to inform you what our next steps are across the next year or next few months. And we want to continue to embed the family hubs offer and develop a clear pathway for new parents for perinatal mental health and infant feeding, and deliver on the School-Aged Health Improvement Partnership. But in terms of challenges, I think it would be good to have a discussion on how the system could help us address some of these challenges. Do you want me to ask about this, Jyoti, or because I know when in our pre-meet we said we'd have some questions for the board, and
so I think these challenges are for us to address collectively, and it would be good to have some discussion about how we might do that and what partners can contribute to some of the challenges. And perhaps I'll start us off actually, because it's not up there, but I think something that's been causing me increasing concern is what we're doing for looked after children, and what more we can do collectively. And how we both ensure they have a good start to education and a good end to education. I think there's so much more we could do for that particular client group. I think the increased demand for mental health services is a problem we're all well sighted on, but I think does need additional partner contribution to address both the prevention end of the spectrum, but also, I think all the way through, and probably we've got too much at the top end being spent and not enough at the bottom end of the spectrum. And I hear that echoed in conversations I have with other people as well. Inequalities, excuse me, that continues to be a problem. And you've all received my annual health report that sets out some ways that we might collectively tackle that particular issue. Workforce issues around health is, specialist workforce, and we have been working with the providers to develop a broader skill mix to address some of those issues. So I think the next one relates to workforce as well. And then governance is the final one, and probably that one we would take offline to discuss. Yeah.
Thank you. I have Dr. Neil Mulder as well.
Hello. Yeah, so just yesterday we had our integrated neighborhood refresh meeting where we were thinking about what projects we might do over the next 3 years. And certainly helping people who are young children is definitely one of our priorities. I guess the recipe, what So our primary care network looks after about 60,000 inner city Peterborough patients. The majority of them are younger ages, so working age and children. Populations that most people would label hard to reach. We don't find them hard to reach because they reach our service every day. And I think the recipe that we've learned in terms of looking after our population is if we are directly able to book people into support, that makes a huge difference. So as soon as we signpost or give a leaflet or give a telephone number or give a website, people don't engage with that. But as soon as we facilitate their kind of booking into a clinic or into a space or into an activity, we get far better results. So I think kind of, there's some great work going on at the moment, but it's kind of like, how do we make these things accessible for those inverted commas hard to reach populations by facilitating their access to these services? I would say that a number of different initiatives, some of which are about to come online, some of which have probably been online for the last 6 months. I would think if we asked GP colleagues across Peterborough, for example, they wouldn't be fully aware of them. So I think there's some work we can do together to kind of, as things come online, talk to each other, make sure that we're signposting, but also building that relationship where we can actually directly facilitate someone to either be kind of booked into a service or for that service to be co-located. In the last kind of 6 months, we've brought on things like the Richmond Fellowship, holding clinics. We're about to start English as a second language. There's employment advocacy. And what we find is that if we signpost someone to the job centre, they won't attend. But actually, if we facilitate those conversations to be within practice or within the community, we have a really high attendance rate. So I think it is about how we join up the work that's going on and how we have facilitation between the different sectors to empower this work to have the greatest effect.
Thank you. I had Stuart Francis next.
Thank you, Chair. Could I just drill down into one part of the report? I was looking at absenteeism because this is something that clearly is going to affect outcomes. And when one looks at these figures, they really are, when one looks at the national figures, they are extraordinarily disappointing. Almost twice as many pupil premium children are going to be absent than others, and exactly the same for children with child protection plans and also SEN. I mean, in terms of health inequalities and levelling up, this indicates to me that we're building up a very big problem for the future in terms of outcomes. So my question is, how far have we drilled into why that is happening locally? Because I believe that there are similar figures locally. I'm wondering how much of the absenteeism is driven by, and I'm aware of this, parents feeling it's just not so important to go to school because COVID, they didn't go to school. And so now they're not going to school. And how much is actually linked to health, children being unwell, whether they've got long COVID, whether they've had an MMR vaccination, because that's heading our way to hit, which is going to create more absenteeism. And I'm sorry it's a long question, but I'm wondering how much we've drilled into that, because I think there are increasing problems down the road for us if this isn't addressed. And also, sorry, one final point. My guess is there are some schools that deal with this better than others. And where is the learning?
So very, very happy to come back on that. And I think you make a really pertinent point, particularly for children being in a school setting, opens access to other services, and being at home, it's much more difficult to reach out. Just to reassure you, we have live access daily to individual schools' data. So we are monitoring individual pupil levels. The one positive I can probably report is the data you have here is the last published set, which relates to the last academic year. there is improvement in this certainly for the autumn term. We have seen improvement. I did look at Peterborough's and Cambridge's data against national similar position, but improvement in the overall percentage coming in. I think I also need to really be clear, our absence issue is not due to holidays. We are very good as both local authorities at chasing parents to make sure they are in. The biggest challenge we have is around illness. In our data, unauthorised absence is actually solid and good across both local authorities, but the rate of illness is higher than national. So we are starting now to work through what's behind that. And I think the point you made about parental perception may be one that we need to explore. You know, we do know, and you would have seen Chris Whitty issued a letter to parents at the start of the academic year saying, if you have a cough, a cold, a runny nose, you should come to school. There's no reason to be absent. But I think COVID set a path around some groups and some parents believing my child needs to stay home. So we need to tackle that, and we need to work through the implications that sit behind that. I do think, however, there is a bigger group within that cohort where pupils are struggling to access some services. There is the perception that they need to be at home because of their needs. So the particular growth we're seeing in absence around illness is, I would say, on the whole, relating to social and emotional mental health needs that are coming through with those cohorts. So what attendance teams are doing in both local authorities are working through some very different approaches now, and it ties into the Department for Education's Working Together agenda about working with families around attendance, not about children, not about the school, but what is in that family household that's preventing access to education. You know, and what we are learning is there are often some other factors that we don't appreciate that are causing that challenge. So, for instance, uniform has come up as one issue that's causing a barrier to that. But also that perception of risk around schools post-COVID. So to reassure you, this is high on everyone's agenda. You know, children do not learn if they're not in school. And we are working really hard with our school leaders to do that. We are fortunate in the local area. The DfE have set up, Department for Education have set up attendance hubs. We have 2 in Cambridgeshire, but they serve the Peterborough area too. And their role is to facilitate and share best practice. My attendance team are also doing the same work. So we've had a number of workshops, and I know they've been mirrored in both local authorities, to look at how do you unlock this? You know, is it that door knocking? Is it that reassurance? Is it bringing parents into school to show them what they need to do? Is it engaging other services? That's high on the agenda, and obviously that's starting to have an impact in my view. And you would have seen government announcements recently around doing more of that type of work and investment in that area too. So national issue, local context, but one that we're very much dealing with, and hopefully this data will continue to improve.
And just to add to John's, we are working very closely with the Education Directorate, and we've just commissioned, in the process of commissioning, a school, so it's called school-based, emotionally based school avoidance, or as John said, a lot of it is social emotional issues, sometimes more within the parents than the child actually. Sometimes it's more that the parents have mental health issues or more concerns about sending their children into school. So we have to work with the parents as well as the child. So we've got this commission now. We've got put in some public health funding into school anxiety or emotion-based school avoidance service, which is a multi-tiered, which will work with schools, with parents, with their individual children who are just starting to drop off. It's a red flag that something's not right with the health of the child, and we need to get in there quite quickly before that behavior gets entrenched, and then it's very difficult to get them in. So that's a service that should be up and running from April, working very closely with the attendance teams in both the local authorities.
If I could just add one other point, one of the insights that came out of this School Health Improvement Partnership was the complexity of this challenge, which I think is being highlighted. Some of the mainstream heads actually talked about emotional-based school avoidance, which is great because we've got a program addressing that. But some of the special school heads spoke about, actually, it's not about a mental health problem that's preventing the child from attending school, but sometimes it's health services themselves taking children out of school for health appointments. So that's inspired another project to work with acute hospitals about different ways of bringing health to the child in the school. So just want to make that point because I think there are very different solutions for different groups of young people with different needs. And so we need to be multifaceted in our approach. Just one other point, because it was raised about children with SEND who are absent. I also wanted to highlight another project that's focused on, again, working very much together around improving the understanding and awareness of neurodiversity in schools. And just to make a link to Dr. Moda's point as well, I think there are some implementation elements that he's highlighted here that's really key. That it's one thing to have a range of projects that I've described that meet different needs, but it's another to make them have an impact for children and actually be felt by families, parents, and children. And that's the bit I think that we are working on quite hard at the moment is, what does it mean for health services, for example, to reach into schools, which are very busy places with very busy staff, etc., in a meaningful way that actually helps and doesn't feel like another sort of complexity or challenge to negotiate for school staff. So that's why by joint leading this together, we can make sure that we have the impact we need to make schools feel like easier places for children to be and to learn in, but also have awareness for those children who aren't in schools and how we can reach them as well. Thanks.
Thank you. I have Paul Med next.
Thank you, Chairman. So thanks for the presentation. I think it's very clear to see that there's a lot of really important work being undertaken within this priority. Section 2.6 refers to next steps needing systems support with specific reference to the work with or future work with district councils. So I think the first thing to say is districts have always been keen to engage and contribute. There's a lot of practical things we've been involved with in the past, enabling families to access benefits, including free school meals, community support programs, leisure and physical activity, and importantly, good quality housing. So I suppose my question asked to you is, where can districts add further value within this children and young people's priority going forward? And how can we even more effectively engage with you in the future?
Thanks a lot for that question, and totally recognizing all the work and all the reach that the district councils have, which was why we brought this here about the Healthy Start, because as you can see, although it has increased, we still haven't reached the 100% of people who are eligible for Healthy Start vouchers and schemes. It's a very good nationally funded scheme where all they have to do is they need help to register, and then it's like a credit card they get, which they can use in supermarkets to buy fresh fruit, vegetables, to get vitamins from child and family centers. So that was, if we can just get that uptake up to every family who is able to or eligible can access it. Because when they get into school, it's much easier because the schools promote, they get the free school meals. So, and schools have an incentive in promoting free school meals. It's the earlier on, because right from pregnancy, these families are eligible for this. It's very easy. It's a credit card that you can use in supermarkets. And if we could all promote that and do something about increasing the uptake of that, which was why we put that in. And details about it are there, and we're happy to come and talk at any district council event about it.
Yeah, just to add, we've recently linked up with Huntingdonshire District Council and their food network to start that promotion. So any other opportunities to work with districts around that would be very much appreciated.
Can I also ask one further ask Paul? I think the mention you made around housing is significant. I think schools and early years providers are very good at understanding need, but influencing the built environment and where families can't lead to all sorts of issues. So attendance, housing is a key driver to see that through. So I think a different type of dialogue around how we work together on that would be a really positive way to move forward. You know, what can we influence, what can't we, how do we signpost? Because I do think there's been a bit of a loss of link between the two in the local area. I think there's some confusion over providers. I think it has to be at an individual district council level. What's the offer? Where do we go? How do we influence? Can schools and earlier settings refer in different ways or highlights issues and concerns? Because that leads to the other issues that are coming through, particularly NEETs would be linked to poor quality housing is a very clear indicator, particularly when children are trying to study.
And in terms of housing, it's the damp housing and the giving the right information when health professionals either are seeing children with repeated episodes of asthma, or if health visitors are going in and finding issues with the housing.
Did you want to come back on that, Paul? Sir?
Yeah, just really quickly if I may. So yeah, thanks for that. I'd be really keen to take this offline so we can reflect on what we've done in the past, build on the good stuff, reflect on where the gaps might be and what more we can do even better. So I'll connect perhaps with you, Jonathan, and colleagues following this meeting.
Thank you. I have Councillor Susan van der Ven next.
Hi, thank you, Chair. My question follows on a little bit from the discussion just now. I wondered if we could have a closer look at children, well, young people not in education, employment and training needs. This report touches just a little bit on it, and I assume we will be learning more as both with the JSNA and the School-Aged Health Improvement Partnership. But I was struck by the slide on living in poverty, which is area-based, and it doesn't talk about hidden deprivation throughout throughout Cambridgeshire and Peterborough. And I'm mindful of the Public Health Annual Report last year, which made, really strong statement about deprivation throughout our communities. So if you just take those maps and charts, there is, deprivation is only where it shows, but we know that that's not true. And then thinking about shifting opportunities for that cohort of young people. We have talked about apprenticeships and opportunities to be engaged in some way, but we haven't talked about the infrastructure to access. And maybe that's getting too technical, but I think, well, we have talked about housing and the quality of housing, but the delivery of more affordable housing it is a complicated matter and can be caught up in infrastructure, public service infrastructure issues. And similarly, public transport is absolutely dependent on the entire system working together. And unfortunately, this is not something that's seeing quick results or so I think it would be, to my mind, in the challenges, I would like to see acknowledgement of those very basic infrastructure challenges which enable young people to get to a job, get to an apprenticeship, get to education. I certainly see in my own division, which does not show on the living in poverty map. I'm very acutely aware of the NEET cohort whose chances have not shifted, and you can see where it's going. So that's what I wanted to add. Thank you.
Thank you. And I'll bring John in because there's a lot of work the NEET teams do. But in terms, totally get your point, Susan. I agree that the maps don't show and drill down into specific areas, but the Children and Young People's JSNA, which is why we are producing that, will have more detailed local level data, which you can then drill down and look at that, and you can look at trends and how they change over time. About the transport, I'm not sure what we do, but the NEET teams in education do a lot of work in terms of that.
So yeah, I think we'd be very happy to bring back some more information on NEAT. Obviously, we're waiting to see the latest cohort data coming through because that's the group that's just left school. I think a couple of things to recognise in that area. Schools are focused and working incredibly hard to improve the quality of their impartial careers advice and guidance. And that's starting to see some yields. So things like understanding of apprenticeships, opportunities into alternative apart from in a school-based sixth form provision is growing, and you know, that's going to be a focus area. I think the challenge we're going to continue to have, though, is that the curriculum in our schools is still limiting. I think the announcement by the Prime Minister around a review of education, Key Stage 3 and Key Stage 4, including expansion of English and Maths to 18, is an interesting area we'll need to engage with and gear up for. And I think those pathways into alternatives are going to need to be tightened. We do know we have gaps around access. So particularly in the west of the county and in the east, there is a shortage of post-16 offer. And obviously working in partnership with the Combined Authority and others, there are plans to review and enhance that and completely acknowledge the point around transport. Obviously, we've had a DFE priority area in Fries, Cambs and Fenland. One of the biggest challenges is how do you get to work and to other areas? So I think that's been flagged. I think, again, it's partners around the table. How do we improve transport infrastructure to support access in a different way? But equally, probably, are there different delivery models and different ways of working that might negate some of that need or different ways of working? So I'm not sure that's an answer, but a recognition of the issues you raise. And I think people are working hard to try and pick up some of those issues.
Yeah, if you'd like to come back.
Thank you very much for that. I guess I would appreciate it if that could be added to the challenges, because, you know, these documents we can point to.
Definitely be added to.
Thank you very much. I have Piers Ricketts next.
Thank you, Chair. Thanks very much for the paper. These are, really wicked issues, as they're sometimes referred to, but I think it's encouraging that you're breaking them down into the parts that you can address. And I just wanted to offer 3 thoughts of things which I know have been done elsewhere that might be helpful, and happy to pick up offline. So in terms of mental health, there's lots of evidence technology out there for children and young people. Things like Chat Health, which has had quite a good uptake across the east of England. So this is an online service providing help for kids with sort of low-level anxiety. We got uptake of that. Mary Elford, who's online, will be aware of Just One Norfolk, which is the online service for families that Norfolk NHS Community and County Council have got. So it's a massive online resource that counters the shortage of health visitors and some of the other professionals who would typically intervene. It's in about 18 different languages. There's some really good evidence correlating uptake and access with results. And then in terms of the data, lots of these things are very long term, so they're quite hard to prove how you're doing. Something that we might find encouraging, certainly on the immunisation, with all the stuff on the Today programme this morning, you could probably have a sort of quarterly update of numbers you've administered, percentages, different types of intervention. I think that would be an encouraging sort of short-term metric against the long-term ones. And then finally, obviously lots of places elsewhere have sometimes successfully addressed some of these difficult issues. So in terms of the impact of families on children's school attendance, things like the work of Hilary Cottam in Wigan, always worth sort of going back to. Greater Manchester did a lot of work on perinatal mental health in the early years of DEVA around sort of 2016, 2017. Again, there might be some useful lessons there. And if it's engagement, whether it's around immunisation, school attendance or whatever, are we deploying community figures like, I'm making this up, but Peterborough Football Club players, or the kind of peers or role models that kids and their families might look up to, because there's an incredible willingness among, whether it's football clubs, other sports stars or whatever, actually to engage on this stuff, because they've got a power as a role model. So just thinking about some of those things, and happy to have a chat offline if that'd be helpful.
Thank you. I think that's really helpful, and thanks for all those suggestions. Just in terms of Just One Norfolk and Chat Health, so we have Cambridgeshire Community Services as our Healthy Child Program provider locally as well. So we take all the learning across from the other regions and adapt to our local circumstances. So we do have some of the web-based and digital interventions as well. We've just launched even getting ready for change questionnaires for the school-aged cohort. So we don't have exactly Just One Norfolk, but we have a lot of things. It's the same community provider. Immunization uptake, yes, we are monitoring that through the immunization board in more detail than what we've presented here. And yes, I'll look up the Wigan, Greater Manchester work on perinatal mental health and road models for immunizations. Again, interesting idea. We can explore that. Thank you.
Thank you. I have Mary Elford on the screen next.
Thank you. I'm Mary Elford, Chair of Cambridgeshire Community Health Services, and very sorry that I can't be with you today. I think firstly, I think we really have to commend the presenting team and those who are working on this for the progress that have been made. I think the papers really show the progress and the extent of the ambition. And I think we can all feel very proud with the way that this work is developing. I had a chat with Eileen Milner, who's the chair of Cambridge and Peterborough Foundation Trust, who are also a key provider with us of a range of children's services within our patch. And I think the thing that struck us is looking at these papers, just the increase that there's going to be in acuity and complexity, and just the sheer scale of the challenge that we're all facing for our children and young people over the coming years. And I guess a question for the report authors and presenters as to whether we've really got enough space for innovative thinking, and Piers has touched on some areas, but I think there's been a lot of work nationally in different local authorities about actually just really can we approach things from a quite different way that takes account of the scale of what we're facing. So I guess that was my first question: is there enough? There's a lot in the papers about short-term work, but have we got enough scope and space to really think about some more fundamental changes in how we approach things? My second point, I think Paul, Susan, and others have made, was around housing, which I think it's just really important that we continue to capture the wider role of partners all around the table in actually having an impact on some of the issues that we're facing. I don't think they can be solved by children's services alone, and I think discussion on housing really captured how important the partner support for this work is. Thank you.
Thanks a lot, Mary, and thank you for that acknowledgement. I think in terms of innovative thinking, we are trying. So the School-Aged Health Improvement Partnership is one way where we are trying to get people around the table from across health, social care, education for that 5 to 19 cohort, because we've done a lot of work over the past few years for the pre-birth to 5 through Best Start in Life, which we started many years ago, which is now flourishing, and we are starting our baby steps with SHIP. And I think that should give us more innovative ideas, because we have people around the table with lots of different experiences coming from different angles at the same problem. And as Steve has pointed out, there's head teachers there giving us solutions of what may work. We are talking to parents as well, and heads and very senior people. As you can see, there's commitment from Director of Public Health and the 2 directors of education to make that work and coordinated. So in terms of, hopefully we'll have some more we are always looking at grey literature, literature in evidence-based for our children and young people's GSNA. We've got a whole chapter on health outcomes, and we're looking at the evidence of what will work to improve those health outcomes, not just in the published literature, but also grey literature and case studies. So I think we're always trying to learn, but there is more to do and lots to do.
Sorry, Jyoti, did you want to add anything?
Yes, please. I mean, I think, Mary, that's a challenge that could probably be leveled to all four of the priorities. And the approach we took was to go for the quick wins in the first year. And I think over the coming year, we've now got to get into some of the more wicked issues. We've got an obesity summit coming up in February, which will be a real focused look at what we could do differently about tackling obesity. But I think I'd like to, over the course of this year, get into some deep workshops around some of the wicked issues so that we can move more into that innovative, different thinking, different approaches space to tackle the really difficult issues that we've got.
If I could just add a quick comment, I think what Mary's highlighted is very true. It's a reality for most of our teams that they're having to respond to the demand and pressures now, and also think forward to the future and try to have the headspace to do that. I suppose the hopeful things I have in mind, one thing which I hope comes through in the paper is, and I would say this working in other systems as well, is that I think what we're doing in Cambridgeshire and Peterborough that is quite bold is really focusing on young children and parents, babies and parents particularly, because just that idea of balancing short and long term, it's a hard thing to do, it's a challenging thing to do, but it's very well evidence-based. I mean, it's very much the right way to go. And I feel really encouraged by that we're doing a lot of work, particularly around prevention of mental health, for example, by intervening in the parent-infant relationship. The other thing I just wanted to say is that I think we'll address this challenge by really making sure we keep scrutinizing what we measure. And I'm going to say here, I think we do have to do a bit of a both and, because one of the things about having school attendance, and for that matter, employment and skills as a kind of common language between us around a good marker that people are healthy and well and enjoying their lives and getting what they need to get out of life, and a good marker of health, that's helpful because it gives us a common language. But clearly we know from the comments that have been made that it's not enough, because it doesn't capture every person in our area. It doesn't capture the people who are quietly suffering great adversity in terms of deprivation. It doesn't capture the people who aren't in school, for example. So I just think we need to keep oscillating between the two. And just again, coming back to sort of Dr. Moda's challenge really is this felt, and if we had young people or parents or families in the room, would they say, actually, this works for me? Or would it just sound like a nice idea, a good thing on a piece of paper? So I think that's the other challenge, is just making it a reality and shifting the dial in terms of people's experience, which I think we are doing with the outcomes framework. But I just think we have to keep holding that ourselves to that challenge, because that's what will actually make a change for people. So yeah, it's a bit of both and, but I think we just need to keep our attention to that. Thank you.
Thank you. And just to quickly add, I know we only had until 11:30 for this agenda item, but I'm happy to give it a few more minutes. I had Councillor Ray Bisbee next.
Thank you, Chair. And this is not a long one. I'm going back to the school readiness. I've had a number of people in schools say that they've got children coming into school, into the reception, who are still in nappies, non-verbal, no social skills at all. And I'm presuming that's because they haven't had a place in nurseries. I'm glad to hear that there's more places, and it's going down to 9 months. It's going to take some time for that to happen. But is this something that's happening around the country, or is it just something local that I'm hearing about, and what's happening about that place? And does it actually impact on their schoolwork throughout their school, because it takes time, 20 odd weeks, to get them to where they should be for actually entering school? So for me, it must impact further on.
So thanks, Ray, for bringing that up. I think from a public health perspective, we see school readiness as a broad spectrum. Are the children, as you say, toilet trained? Are they have they had good oral health, good healthy weight? Are they having had all their immunizations? So in public health, we see school readiness as a broad term with all of these having been achieved. I think in terms of I think we've come to, which is why we focused a lot on the 2.5-year checks in our health visiting check, because we're coming to a stage where there's been children born during the pandemic who are now coming into the education system, and whether that's had an impact because they've not had as much social contact as before. I think it's probably, we haven't got data to actually look at numbers and look at trends and whether this toileting issue has become more of an issue or not. I definitely know from talking to colleagues in the acute sector that constipation is a big problem for which children go into A&E or even go into hospital for if they've got obstruction, which is why in Best Start in Life or Family Hubs, we try and have that same message that it's important what diet you're having, what are you toilet trained, and all of those messages, which as the consultants in the acute trust say, it's not, they don't need to come to Addenbrooke's to get that message. A childminder or a earlier setting, anyone can give that message about a healthy diet, enough fluids, making sure you're toilet trained. So I think that's the other thing, that as a system, everybody can give those same messages and children don't need to end up in hospital with constipation and bowel obstruction if we get it right initially.
Just add, Ray, I think what we're experiencing in Cambridge and Peterborough is a national issue. I think we are seeing children coming into the school system that aren't engaging in early years or haven't engaged with health or other providers. And that's coming through, I think, when we look at the data around our speech and language development and that social interaction element. So, you know, particularly for Cambridge, I'll give the example here, when we look at the outcomes of children at the end of reception, focus on self-regulation, managing self, reading, which comes through that social interaction, are our weakest areas. So I think getting our practitioners really focused on engagement and services, you know, children accessing as many opportunities as they possibly can. That's where the 50 things between 5 is important, will help develop those areas. But we know, particularly in COVID, people didn't engage, and we need to get people back into the mindset. You're quite right to reference the government reforms around early years. I think the access for working parents to early years education, as I would see it, or childcare as it may be described, is a real help, could be a real helpful benefit. But we will need to look at capacity and support and the needs that are unidentified coming in at an earlier stage.
Can I just add a little bit to that? So just in practical terms, some of the things we're doing. So it's been mentioned a lot about the impact of the pandemic and about how behaviours changed then. We are noticing that it has taken a while to get the trust back with families and the habits back with families to be able to have them accessing our child and family centres, our early years settings, etc. So one of the things we've done, we've used Family Hubs funding in Peterborough, but we've been able to find some funding to replicate this in Cambridgeshire, is to bring in a new role around community connectors or key family connectors. They're called slightly different things in different places, but it's about trying to reach out into families to help with that confidence to go back into getting that support they need and being really proactive about it. So we've built back the offer. The offer is there, and it's about access. And we've talked about access in lots of different ways, but access, building the relationships, making sure we have a connected set of services that all understand the offer. But those kind of roles that a significant investment has gone into is helping us have a more proactive approach of bringing families in, and which hopefully will help.
Thank you. I'm a bit cautious of the time, so we've just got a couple more. If we go to Liz Watts.
Thank you, Chair. Great presentation, thank you. And it was probably only 18 months ago that we were all in a room together with all of the different priority areas you know, I think looking at each other a bit kind of like, how are we going to put some shape around this? And you clearly have put a huge amount of shape around it. I think that's brilliant. Thank you. I just have one question, which is on page 23 of the pack. And it's about Ambition 2030. So really pleased to see that you've got ambitious targets. The targets, I'm just wondering if you have annual targets so that as a board, we can track annual performance, because otherwise we're waiting until 2030 to see what's happened.
Yes, there is a trajectory. We have a trajectory that we can monitor on an annual basis. And John, do you want to add?
Yeah, this is such a key target for everyone. We keep an eye on this. Obviously, it's cohort specific. We are seeing some changes coming through, so we will adapt and adjust that. And obviously, the learning from the cohorts going through are really key. But absolutely, year by year, we're monitoring that progress, and we're also reaching out into early year settings to get more information about the children before they reach reception, because this is obviously a measure at the end of the first year of school. So we're trying to be proactive in planning those effective targets and understanding where gaps are to work them through. So yeah.
And also in terms of child development, the ages and stages questionnaire that health visitors complete at 2.5 years, we are looking at the outcomes there. So even before they've entered school, that is part of the health visitor check, and we've got data on where they are at, and we are moving more towards an outcomes-based approach to look at how we monitor those. So yes, it's too much detail, but we have that in the background.
Thank you. I have Anna on the screen next.
Thank you very much. Anna Smith, Deputy Mayor at the Combined Authority. I'm here on behalf of Nick Johnson, who sends his apologies. We asked the question earlier, what would parents say if they were here? And I just wanted to reinforce, I have a background in teaching and school leadership, that need to reflect the complexity of young people and parental situations in our messaging. I'm thinking very much around all the communications I've received in the last couple of days around the DFE's attendance adverts, which has caused some significant upset. You know, I've had parents writing to me who are absolutely desperate to get their children back into school, are facing huge waiting lists for CAMH services, you know, are dealing with immunocompromised young people who haven't been allowed to open a window or put a mask on. All sorts of situations where parents are desperate to get the support they need, but have kind of been told, your child's a bit nervy, but just send them in, they'll be fine. And I know that's not what we're doing here, but I think that need to reflect and understand and acknowledge the huge complexities for those children and young people who are struggling with attendance. I think that's so crucial.
So I think I agree with you. Some of the government messaging, maybe not the messaging we wish to share. So I think one of the things that I've asked my team to put together, and I'm really keen to particularly work with Jyoti on this, is a messaging out to parents about expectations and how to access and where support is and what's appropriate and what's not appropriate. Because I think some of the national messaging is confusing, particularly in light of earlier messaging. So absolutely acknowledge that. And I think what you've heard today about some of the solutions and interventions going on, to highlight that through a letter to all parents would be incredibly helpful, I think. So I think, yeah, it's on our agenda, and certainly we'll look to clarify perhaps the appropriate messaging that needs to go out.
And just to answer your question about the CAMH waiting list, I think there's a lot of work that's gone in. We need to acknowledge that in terms of trying to reduce those waiting lists. There's a lot more single session thinking and innovative. Mary asked, are we thinking innovatively? We are moving towards single session thinking, so that rather than waiting for a long time to have an assessment, interventions happen very early on. Sometimes just that one single session is enough to guide parents and the child through some self-help modules, and also address some of the, so very conscious that it's important to not just keep people waiting on waiting lists. Lots of innovative work going on in that sphere as well.
Thank you very much to Raj and the team for your report. Thank you, members, for the discussion. I will now move on to the recommendations. The Health and Wellbeing Board and Integrated Care Partnership is asked to agree the targets and consider the progress described in the report, identify how the joint Health and Wellbeing Board, Integrated Care Partnership Board and wider system can provide support to some of the challenges and next steps described in the report. Are we happy to support these recommendations? Okay, I will take that as agreed. Okay, members, I will now move on to item number 4, the Pharmaceutical Needs Assessment Supplementary Statement. I would like to invite Ian Green to introduce this item.
Thank you, Chair. Yes, I'm Ian Green. I'm the Team Manager for Health and Policies within Cambridge and Peterborough Public Health, and I'm also Chair of the Pharmaceutical Needs Assessment Steering Group, which pulls together the P&A on behalf of the board every 3 years, but also we have a duty to keep the P&A up to date. So the report in front of you is in 2 parts. There's the main report and there's the appendix, which is a supplementary statement. As I said, the board has a legal duty to keep the P&A up to date. And we do that via 2 main methods. We either produce a supplementary statement, which gives a short update, or we have to produce a whole new P&A. And the report in front of you basically is asking you to look at the supplementary statement and agree it, and agree that producing a complete new P&A is disproportionate at this time. So just to quickly go through some of the background, over the last 12 months, we've seen significant changes to pharmaceutical services nationally, and those have been reflected locally. So we've had the closure of a number of Lloyd's branches, we've had a closure of a number of Boots branches, and the P&A has reflected those changes. The role of the board is to look at, does that create a significant gap in terms of access to pharmaceutical services? The view of the steering group through myself and supplementary statement is no, because what we've had is, particularly with the Boots closures, there are other pharmacies nearby. So although there may be a reduction in the number, actually the majority of people in Cambridge and Peterborough can still access a pharmacy within 20 minutes. I think it's worth just looking at what those changes have been. So the report outlines the changes to opening hours. It also outlines the changes to what we call 100 hours pharmacies. So they're the pharmacies that are contracted to open for 100 hours per week. And earlier on in the year, the government allowed pharmacies to reduce that to no less than 72 hours. So over the past 12 months, we've seen some pharmacies stop producing 100 hours of activity, but have gone down to 72, 78, 79. So it's very pharmacy dependent. We've also had a number of closures, and we've had a number of the 100 hours pharmacies close. That left us with a position of having 1 pharmacy in Cambridge and Peterborough that's still open for the 100 hours. And that's within Peterborough. So the supplementary statement gives you the full picture of where we're at locally with pharmacy provision, where those closures are, the reduction in hours we've seen, and that updates the current P&A. So the board has a choice. It can either accept the supplementary statement and we publish it as an addendum to the main P&A, or should the board wish, we could do a complete new P&A. A P&A takes a minimum of 6 to 12 months to do, and my feeling is that's disproportionate at this time. One, because it's a significant amount of work, but also we're not settled yet. So just this week, we've had another pharmacy close. If we trigger a new P&A on a regular basis, we'll be in a constant churn of updating the P&A. And the best way to keep the P&A up to date is to produce a supplementary statement and issue it as an addendum to the main P&A. So that'd be my recommendation to you as a board. I think the other thing just to be aware of is the P&A is used by commissioners on decision as to whether to open a new pharmacy or not. So that therefore is important that it is up to date. There are rules and regulations on who can open, who can't open a pharmacy, and the P&A is one tool that is used by commissioners when they make that decision. If the P&A says there's no need to do pharmacy services, then it's very difficult to open a new pharmacy. If the P&A says there are gaps, then it's slightly easier. So looking at the map of pharmacy provision, which is in the back supplementary statement, you can see the geographic spread of pharmacies, and you can see actually there are no main geographic gaps to accessing pharmacy services. You'll also see in the supplementary statement the travel times. So once again, most people within Cambridge and Peterborough can access a pharmacy within 20 minutes. Those areas where you can't tend to be on the borders. So if you live in East Cambridgeshire, you may get your pharmaceutical services from Peterborough. It's not Peterborough, sorry, Newmarket. So there are lots of cross-boundary issues. So it's important that we've also included a map showing where the access to pharmacy outside of our Wellbeing Board area is. It's also worth just stating for the board and the ICB that the duty is on the Health and Wellbeing Board to produce the P&A. Therefore, it covers the geographic area of Cambridgeshire and Peterborough local authorities. Obviously, the ICB is slightly different because it covers Royston. So we've had a conversation about making sure that we include Royston as part of that discussion to make sure that we don't have specific gaps. So the recommendations are in the paper. I'm happy to take questions on either the report or the supplementary statement. Thank you, Chair.
Thank you very much, Ian. Anything from the members? Any questions? John O'Brien.
Thank you, Chair. I just wanted to say I think it's very clear and helpful that we've got this alongside the update on community pharmacies that we're coming on to as well. I think the reasoning that Ian has set out for the supplemental statement as opposed to entire revision at this point seems to me to be clear. So I'm certainly in support of the recommendations.
Okay, I will read out the recommendations if there's nothing else from the members. We are asked to consider the changes to pharmaceutical services across Cambridgeshire and Peterborough as contained in this report and supplementary statement attached as Appendix 1. We are asked to agree the supplementary statement at Appendix 1 and publish it as an addendum to the main Cambridgeshire and Peterborough Pharmaceutical Needs Assessment 2022 as per the requirements under the NHS Regulations 2013. We are asked to agree that producing a new pharmaceutical needs assessment would be disproportionate at this time, but the provision of pharmaceutical services will be kept under review. Are we happy to support this recommendation? Thank you. I'll take that as agreed. We'll now move on to agenda item number 5 on an update on community pharmacies. I would like to invite Sati Obi to present on this item.
Thank you, Chair. Yes, my name's Sati Ubi and I'm the Chief Pharmacist of Cambridgeshire and Peterborough Integrated Care Board. I'm delighted to be able to bring this update to the board to show the significant changes that are currently taking place in community pharmacy. These changes are the beginning of some of the most significant changes seen in the profession for some time. Community pharmacies are the backbone of primary care and are often used by our population more than any other healthcare services. We saw this particularly through COVID, where their doors remained open to our population throughout the pandemic. The sector has been hugely challenged with workforce and funding issues, but this paper shows the scope and possibilities of how our pharmacies can really help to improve the health and well-being of our population. We made a commitment in our health and wellbeing integrated care strategy to make best use of our community pharmacist clinical skills. The services outlined in the report begin to do just that. They show how we can improve access for patients to health services, allowing our population to have their blood pressure measured, obtain oral contraceptives, and have a range of infections treated by our pharmacies without having to go to the GP. It also shows how we've listened to our local pharmacists and addressed some of their challenges by ensuring that financial commitment is made available to support them. So the benefits of these clinical services will not just be seen by our population, but also by the system as a whole, reducing some of that pressure on general practice and on our hospitals. I'd like to stress that many of the services included in the paper are in the early stages of development, but as you can see, the numbers of patients already passing through these is very encouraging. I'm very happy to take questions on the content of the paper. Thank you.
Thank you very much, Sati, for the paper. Members, are there any questions? Yep. Councillor Susan van der Ven.
Thank you very much for the paper, and I certainly recognize some of the new services, and it's been very encouraging. I just wondered if you could say a little bit more about how this group, how the Health and Wellbeing Board ICP can support the continuation of this, because I think we're required to do that, aren't we? Thank you.
Yes, sure. So as with any new services, they take time to embed. It takes a change in culture, the way our patients access health services, and also the relationship between healthcare professionals in order to embed these. So there's something about really encouraging our local population, making them aware that the services are different now, that they can access clinical services through community pharmacies, and also I guess some of that feedback as well from members on how those services are beginning to embed.
Thanks. Are we able, I don't know, that there's a real communications opportunity there, and I don't know where is that something that can be taken up across the system? How is that being coordinated? Thanks.
So I'd echo that, and I think there's an opportunity for us to really think about, as we plan new developments and infrastructure opportunities around integrated approach to pharmacy, and recognising, as Sati has said, that the provision provided by pharmacies and the advice and support is not only for health and care advice, but also as a real role of part of our anchor institutions and how we help communities to feel safe in that point of contact. So I think there's a role for us all about really promoting the role of pharmacies for that broader support. I think there's something around the support for pharmacies as part of our Section 106 money. So when we think about health and care infrastructure, and also in terms of our longer development plans, looking at new towns, looking at all the developments across the county, how we make sure the provision of pharmacy as a part of the infrastructure and support that those people who work incredibly hard in those services. And the final thing I'd add around that is over the last few months, the Integrated Care Board executive visited pharmacies, and we were all consistently struck by the commitment of those individuals and about their commitment to providing a service to that local population alongside GPs. And I think that's something we should not underestimate, and the impact that those individuals feel.
Thank you very much. I have Stuart Francis next.
Thank you, Chair. I think patients are frustrated because they have no idea what they can get at a pharmacy and what they can get from their GP. And we hear of so many cases of patients going to the pharmacy and being told, well, actually, we don't do that. You've got to go and see the GP. So they read in the newspapers all the stuff about, primary care. We're going to look at it together. With the GPs are doing more than they've ever done. There are difficulties with access in some GP practices. Turn to the pharmacist, and they go to the pharmacist, but they can't give you antibiotic eye drops for very fairly simple conditions. So I think my plea is, as this is rolled out, can we just tell patients what you can get and what you can't get at your local pharmacy? Because I think that would be very helpful to them.
Yes, there's a national comms program at the moment that's being developed, and we're waiting for that to come out, and then we'll see how we can locally support those messages as well with our population. I absolutely agree. The comms is incredibly important, particularly with the 7 new conditions as well, which will involve the provision of antibiotics by community pharmacists.
Sorry, Chair, could I just add that there are some fairly simple communications that have taken place. For example, when GP practices ceased prescribing certain things, don't come to us for paracetamol because it only costs 59p at Sainsbury's. These are the things that you don't come to us for. Can we have communications about where you go to get things that you do actually need? I think that's the point. Sorry, I am expressing a frustration, but I do believe it's out there.
Yes, no, of course. Thank you.
Thank you. I have Neil Moder next.
Hi, Sassy. Thank you for your paper. I have to agree that I think community pharmacy and general practice working as close together as possible to help support the patient population and the community is the way forward. And obviously, I've got to declare my interest. I run a GP surgery, I run a community pharmacy, and I can see a lot of opportunity given the amount of work and pressures that are out there of being really clear about what is done where. So I think historically, often GP surgeries and pharmacies can argue over things like flu vaccines. And I think kind of moving beyond kind of arguments into kind of deciding together what activity happens where, how do we therefore concentrate our workforce on the right bits? Because there's certainly more than enough work to go around. And I do think the approach by the ICS has been very supportive. So the ICS have communicated well with general practice about this new opportunity. There's been lots of webinars and things like that. But as everything, as you said, Sati, it's going to take a bit of time as these things come into fruition. People understand kind of what can be done, what can't be done, what are the exclusion criteria, what cases are safe, not safe, how do you manage the clinical governance? So I think this is a real opportunity. And I'd just say that I think from a GP perspective, we've been communicated well. And from a community pharmacy perspective, I know the ICB, the pharmacy leads within the ICB have also been out looking at potential future ventures like Pathfinder projects, managing hypertension out in community pharmacy. So I do think that the clinical role of a pharmacy, that space is really exciting at the moment. And thank you for your paper.
Okay, thank you. I have Councillor Ray Bisbee.
Yeah, sorry, this is just a bit of accuracy here. On 2.3.3, the System 1 pilot, the last point, it says the pilot is ending on the 31st of January 2024 due to the benefits demonstrated and outcomes achieved. Our system has agreed to fund the license to continue the use of the System 1. So is that just a printing out that it is actually because of the actual benefits that you continue in the year?
So the pilot was just in a couple of areas, and so just for those, we're continuing to fund the licenses just for those areas, and not for the whole, not for the whole patch.
It's just the way it reads. It seems that it was to finish on the 24th due to the outcomes that they were seeing. I think the funding was due to the outcomes. Continued funding. It's just the way it's read.
My apologies.
Yeah. No. Thank you.
Okay, thank you very much, and thank you. If there's no more questions, members, I will move to the recommendations. We are asked to consider the progress described in the report, and we are asked to identify how the Joint Health and Wellbeing Board Integrated Care Partnership and wider system can provide support to progress the areas identified in this paper. Are we happy to support these recommendations? Okay, I'll take that as agreed. Thank you.
Thank you.
We now move on to agenda item 6, the Better Care Fund Quarter 2 reports. I would like to please invite Caroline Townsend, Lisa Murray and Sandra Pedley to present on this item.
Thank you. I'm just going to give a brief overview. I'll start first to give a brief overview of Q2 performance for Cambridgeshire Better Care Fund. I'm going to hand over to my colleague Lisa to update on their Peterborough Q2 performance, and then Sandra's kindly going to give an update on the Better Care Fund evaluation. So we will make it brief and assume that the paper has been read. So just in terms of the Q2 performance, so although this is a Q2 report, I just wanted to note that this is actually based on end of Q1 performance. Obviously that is just the first quarter performance, so we have only got the sort of early trends for the year at the point of writing this report. Across the 5 metrics for Cambridgeshire, at the end of Q1 we are on track and performing well against the discharge to normal place of residence, but we are challenged against the remaining metrics, particularly the avoidable admissions and falls metrics, which currently are very much not on track to meet target. Sandra will just add a little bit of further information around the falls metric shortly, but part of the issue and challenge around that is partially due to some change in the guidance, particularly around head injuries relating to falls, which is making the performance of that metric particularly challenging at the moment. In terms of residential admissions for older people, at the end of Q1 performance wasn't on track to meet target. However, we have since had Q2 performance, and we are seeing a slight improvement in Q2 performance. I think it's important to note as well that when we look at performance compared to cumulative position this time last year, that actually the admissions to residential homes is actually lower than the year to date this year than it was at this point last year. So we are currently anticipating the end of year position to be overall lower numbers to what we saw last year, but we're not quite sure that we're actually on target to meet the target at this point. Again, reablement, based on what we're seeing at Q2, again, we have seen a slight increase. We've increased our performance from 73.3% in Q1. It's looking more like 76% at Q2, so we are heading in the right direction. Also, I think it's important to note that we've got really good flow through reablement. We have no waiting lists. People are generally staying an average of around just over 4 weeks. So we've got good flow through the service, and we have independence outcomes of around 78% in the service, where people are not requiring any further onward care, so indicating that the service is delivering good outcomes. But we'll be obviously continuing to monitor the metrics closely as the year continues. I don't know, Sandra, if you just wanted to mention the falls metric at this point before I hand over to Lisa.
Yeah, I can do. Sandra Pedley, Associate Delivery Partner from the ICB. The falls metric is quite a new metric as far as reporting under the BCF goes. So there may be a couple of things. One, we may have overestimated our target and made it quite challenging for us to meet, whilst we understand the data and the direction of travel with that data. But as Caroline mentions, there has recently been some changing guidance on the treatment of falls, particularly where a head injury is involved. So we are seeing more conveyances to hospital for that particular incident. So we're trying to look at the data and whether we can put something in place where we can treat those within the community, where people can stay at home without a trip to hospital. So back to you.
I'm going to hand it over to Lisa to give an update on Peterborough.
Hi, Lisa Murray, I'm Head of Commissioning for Peterborough Adults. From the Better Care Fund in Peterborough, we're pretty much on track. Sorry, can you hear me? pretty much on track on all of the metrics except for falls, similar issue to that which Caroline describes and Sandra has elaborated on. The other one that we're not meeting currently is reablement. We're at 81%. There are a number of reasons for that. The percentage that we're seeking to achieve is around about 84%. We are seeing higher acuity for people leaving hospital, which does impact on the ability to reable them and keep them at home after the 91-day period. Indications are fairly static on that particular target for Q3, which is Q2 data, but we are working to determine what we can do to improve it. Other than that, the targets in Peterborough are on track.
So whilst we're talking about metrics, you'll notice there's a slight difference between Cambridgeshire and Peterborough on avoidable admissions. So avoidable admissions are admissions to hospital for certain ambulatory care conditions. These tend to be the long-term conditions. So I think what we're seeing in Peterborough, where we seem to be on track and a reduced amount of admissions for these type of conditions, could be down to the work that's been undertaken in the more deprived areas for these conditions. So we're starting now to see some of the results that are happening within primary care, where the patients are being treated more within the community and the focus on those patients. So that's a positive, and hopefully we'll see that start to decline within Cambridgeshire, but we will be looking at other measures we can maybe put in place and how we use the urgent community response services and things to hopefully keep people at home and avoid their conveyance to hospital. So the next item I want to cover is the Health and Wellbeing Boards and the ICP agreed to do a review of the schemes under the Better Care Fund to make sure that we align with our priorities as a system and also meeting the objectives of the BCF. So we have worked with the Better Care partners locally and appointed health integration partners to undertake the review for the system on our behalf. We've just started working with those in the last couple of weeks, so they are starting to gather information and data and do a desktop exercise looking at the schemes. So the plan will be to come back to Health and Wellbeing Board to present recommendations. There'll be an interim opportunity in March for a session as part of the development sessions where you're able to input into those recommendations as well, with the final recommendations coming in June.
Okay. Thank you very much for your report. I'd like to open it up to members for any questions. Anyone has any? Okay, nothing. I shall move to the recommendations. Sorry, did we have someone? No. I'll move to the recommendations. The board is invited to approve the Q2 return to NHS England and to note and comment on the scope of the Better Care Fund evaluation. Are we happy to approve and support this? Okay, take that as agreed. Thank you.
Thank you very much.
We shall now move on to agenda item number 7, which is the corporate update, including the forward plan. If I could invite Martin Whelan to present on this item.
Thank you, Chair. So there's 3 very brief elements. Firstly, the responsibility for setting your own meeting dates is delegated to this committee. Delegated to the board. So there are 4 dates which have already been tested with the key attendees. So the board is invited to approve those. Secondly, the terms of reference have now gone through the local authority governance processes and have been approved. They are included just for information to close the loop on that process. And due to production error of the agenda forward plan didn't get pulled out as a separate item on the agenda. So there's just also the 3rd item is an opportunity for this meeting to comment on the forward agenda plan. Thank you, Chair.
Thank you, Martin. There's anyone who would like to add anything? Yep, Kit.
Thank you. So I was hoping to be able to suggest to the board that about a paper to come as part of the development session, the 22nd of March. We currently have a development session, the 22nd of March, around infrastructure. However, board members may be aware of the Work Well bid that we have submitted recently. We have been successful in our leadership capacity bid and have just received 90,000. We have put in a bid for over 2.9 million, which is an integrated bid between health and care that will help support people who are disabled and people with health conditions to stay and succeed in work. So it's really aligned to the work we're doing across our partnership. And my ask is that perhaps we could discuss this instead on the 22nd of March. We're hopeful we'll have the outcome of that bid by that point in time, and we'll be able to bring those recommendations to this partnership and discuss how we might work with that together.
Thank you. And Councillor Susan van der Ven.
Thanks. Thank you. I see that the dates here on the paper do indicate a development session in 2025, but I think our intention was to try and make use of our the other half of the day whenever we can, and these have been so good. So just to alert all of us here, yeah.
So my understanding was the plan was to try and use every other meeting. Sorry, 2 a year. We had some difficulties identifying the October date for the formal meeting. There is a piece of work that I need to do to check whether we can accommodate a development session earlier in that day, or if that doesn't prove possible, look at an alternative date for a development session round about that period of time. So that is referenced in the report, but apologies for not pulling that out.
Okay, thank you. If there's nothing else from members, I shall move on to the recommendations. We are invited to approve the meeting dates for the municipal year 2024-25 and to note the approval of the revised terms of reference. Is this agreed? Thank you very much. I'll take that as agreed. That concludes the meeting. Sorry, Stuart Francis.
Yeah, I'm not sure if this is the appropriate time, Chair, but I just wondered when the Health and Wellbeing Board and the Care Partnership might consider it worthwhile to look at the role of arts and leisure in terms of delivering better health outcomes. This is not just about physical health, it's also about mental health outcomes as well. And I think there is an important role there. This is against a background of less money being spent on arts and leisure. And in particular, I would cite an example of the regional pool that I know you're familiar with in Peterborough, the closure of that major facility in the city that helps to keep the population fit. And that follows on the fact that the provision for swimming in Peterborough was inadequate before the regional pool was closed. There was not the necessary capacity. So I just wonder at some future time where the board may consider that, as well as having the presentations we've received today, we might look at how arts and leisure plays a role in health inequalities, health outcomes.
Thank you. Councillor Susan van der Ven.
Yeah, apologies, Chair. It hadn't been clear in my mind where the forward agenda planning was. But following on actually from Stuart's point, I wanted to ask if we could bring into our agenda something around the integrated neighborhoods. This is so important to our existence, but we haven't had, we've devoted our time to other things. And if you take that term more broadly, I think it does offer the chance to consider, sport and leisure, as you've just said, and culture. So perhaps we could ask our officers to consider how we might bring that into our agenda.
Neil Moder.
And just to say, the arts and leisure is a big part of that work. I mean, it doesn't build a swimming pool, but it does kind of make use of things like assets like Peterborough Sports, Living Sports, and things like that. So I think we could integrate the two together. However, I guess the bigger piece might be what's going on with leisure facilities and things like that. However, integrated neighbourhoods, I think, definitely could give some tangible examples. And I think, for example, Arts on Prescription has just literally launched again in the last 2 weeks in our system. So there are some there's some the bits of work that are coming that we could showcase here. Absolutely.
We have Julie Farrer.
Thank you. I think it's really important. Thanks very much for bringing this up. I think arts and leisure are a key element to actually keeping our communities healthy. I think that what I'd like to do is I think we should schedule something in. I think we need to separate arts and leisure a little bit because I know the pressure that leisure services are on, particularly from a district council perspective. But from an arts perspective, there's a piece of work going on with the Arts Council, and actually I'm aware of something that might be along the track in a few months' time. And if we give it a little time for that, I could actually bring something revolving around that to the group. I think that might be really helpful. It's targeted work in certain areas within our system that they're looking at funding, as in a big pot of money to develop arts for health within the system. So I'd like to say that it'd be really great if we could actually do that, but it needs to be scheduled in from my point of view a little bit later.
Thank you. We have Anna Smith.
Thank you. And I just wanted to give my endorsement for what the Vice Chair has been saying there. I know if Nick was here, what he'd want to say is that everything has a health and wellbeing aspect to it, and really considering things in the past like cultural and community services that we haven't always seen as having a health impact, but really do. And I think increasingly we're all appreciating that. So I absolutely want to give my my endorsement to trying to get these things very firmly on the agenda here for us to talk about.
Thank you very much, members. If there's no more business, then I will say that the date of the next meeting will be the 22nd of March. And thank you for attending today. I declare the meeting closed.